Hi, and thank you for having me. I have nothing to disclose, and I will really try hard not to speak super fast, but as my mum tells me, when I'm nervous, I speak fast and I sound like a duck. So with those words, we'll press on. So what does it mean to live well? And how do we judge this? So is living well having a good performance status? Is living well having a good quality of life? And I think all of us will agree that living well means you're having a good quality of life. And I think this is quite an interesting idea because I've been to a few different education sessions, and I went to one about a year ago where they were talking about one of the most recent treatments. And they were doing a study and they were saying, okay, well, how do we measure someone's quality of life? And the only two ideas that they had around how we measure quality of life is the person breathing and how are they walking? And I don't know about anyone else. I've never come out of having a really good day going, I breathed so well and I walked so well and that was the best day ever. Generally, I come out thinking, I went out, I did something I enjoyed, I was with the people I loved, and I came out feeling really good and rewarded. And that's what I feel is living well. So, looking at the quality of life indicators by the World Health Organization, and I guess they should know what we should be looking into, they say we should look at physical health, psychological health, social relationships, and environment. And I think this is great because other people have already touched on this, so I'm preaching to the choir, kind of. I looked at a couple of studies as well because obviously we need to look at studies, and there's heaps out there around how do we talk about quality of life and how do we prove this. But two that I really liked and two quotes were that the first from Gill et al., and it's quite an old one, but quality of life can be suitably measured only by determining the opinions of patients and supplementing or replacing the instruments developed by experts. So really, what does this say? The patients are the experts. Also, another one by Borokel, and I'm sorry if I don't say that right, found that treatments should be evaluated by their impact on quality of life and patient-reported outcomes as well as survival. And what this says to me, all of this, is that what we really should be focusing on is what is important and what is meaningful to the patient, not to us. We know what we should think they should be doing, but that doesn't matter. If a patient doesn't really care about, oh, can they walk 100 metres, but they care, can they go to the pub and see their friends, that's what's more meaningful. So I think we're all really good at looking at this, and I think nursing and allied health, we are really lucky. We get to know our patients, we get to talk to them, we get to find out what makes them tick. But it isn't just, just one discipline that looks at this. And so this is just an example of a couple of the different models of practice out there. So I'm sure a lot of you are familiar with the pain management one by Dame Cicely Saunders, because she's the queen of palliative care, especially in the UK. But also here we have the rehab model in the middle, which is a physiotherapy tool. Down the bottom, this lovely one with a circle and a triangle is our sort of OT be-all and end-all, the Canadian model of occupation, person and engagement. And then also I popped in a dietitian one because, even the dietitians, they're thinking about how we look at people holistically. So what are the common themes that has come out of this? Well, much like the World Health Organization found, we need to look at the patients physically, socially, emotionally, and spiritually, or what are their personal values. And I thought this could be quite interesting when we're considering side effects from treatment, because I think we all know what the general symptoms are that patients are going to get if they have a lung cancer diagnosis. And we do know what they're going to get from treatments, but what do we do about those treatment symptoms? Do we just say, hey, they're expected, or do we actually address them? So I went through, with the help of Cancer Research UK, and I went through all the most common treatments that patients are having at the moment and the most common side effects of these. And so what I thought I would do is talk about 4 of the physical symptoms that people experience and how we can address this and what onward referrals or considerations might be good to help people live well. So I'm going to go through nausea and vomiting, tiredness and fatigue, breathlessness, and my personal bugbear, peripheral neuropathy. So I'm not going to tell you about liver changes because I couldn't tell you anything about that. Okay, so when we're thinking about nausea and vomiting, physically what do we need to think about? Well, initially we're going to assume that there's probably some poor nutrition. So what happens when we're not getting enough nutrition into us, we can't do what we need to. So straight away, we're doing less, we're getting more deconditioned, so our mobility is going down, our fatigue is going to go straight up, because as soon as those muscles get weak from doing less, the fatigue is exacerbated. We're going to have difficulty just pretty much engaging in those daily tasks that we want to do. And it can also result in things like constipation and headaches. From a social aspect, yeah, it's probably going to impact on most things that you can do. So as previous speakers were saying, you know, it stops you from getting out and socialising. When we think about what we usually do with our friends and family if we go out and socialise, I think most of us would say that generally there will be drinking or eating involved. Now, if you've got nausea and vomiting, straight away this is going to be much more complicated for you to do, and it totally gets rid of a whole social aspect of your life. It can also stop you going to work, and that's a huge role for most of us. I mean, we all here recognise as what our profession is, otherwise we wouldn't be here, would we? So straight away socially, what we do, that's gone out the window. Emotionally, well, I think we all know that there's a high level of stress and anxiety associated around nausea and vomiting, and that can impact on also our ability to access the community and what we can do. And then this can result in us feeling quite socially isolated. And then, you know, low mood possibly follow. And also, for me, the biggest one, loss of pleasure in food and drink, because, you know, it's great. And from a spiritual or a personal values point of view, as I said, it can impact on everything that we do. So straight away, it's that loss of role of who you are, of what you identify as. And it can impact on your ability to attend religious events or protocols, because a lot of them are related around food and drinking. So it's not all doom and gloom, thank God. What considerations or onward referrals would be beneficial to think about? So obviously, number one, dietitian, because they're the ones that are going to help build our patients up and give them nutritional advice and help with weight management. And also our psychological support around the stress and anxiety management. But it's also really worthwhile considering other disciplines, so such as physiotherapy, because can we be strengthening and increasing exercise tolerance and increasing mobility? Can you refer into occupational therapy for some fatigue management, or looking at adaptive equipments and task modification so that people can manage to do things more easily when they're deconditioned due to the nausea? Also, just re-engaging them in those meaningful occupations, because, you know, really that's what it's all about. And unfortunately, in advanced cases, you know, do we need to look at care? Also, there's a role for complementary therapy around relaxation and stress management, also aromatherapy and acupuncture. So it's sort of, you know, everyone's involved. So moving on to fatigue, and a lot of what I'm saying, unfortunately, is going to be repeated. But once again, people are tired, they do less, they get weaker. So they get deconditioned. Once again, they can do less, it gets spiralling out of control, as I'm sure we've all seen, and they can't keep doing those daily tasks that they want to be doing. Unfortunately, it can also really impact on our memory and our concentration, which makes it harder to be doing, you know, our vocational tasks, and can also impact on exacerbating pain, and it can also exacerbate breathlessness. So, once again, socially, pretty much it impacts on everything that we do socially. If we're too tired to go out, if we don't have the motivation, we withdraw. And it's really unfortunate that the first thing I really see with patients is often the first thing to go out the window when they're fatigued are those things that they find meaningful and rewarding to themselves and fun. You know, we've all got to have fun in our life, but straight away they go, oh, I don't have the energy for that. And this, once again, results in that idea of social isolation, stress, anxiety, low mood, and impacts on their sense of self and their role, and also can impact on religious protocols. So, what do we need to consider? Well, as all OTs, we'll throw our hands up and say, yes, we are the fatigue management people. So have a think about referring into occupational therapy. Do we need to look at some adaptive equipment? Do we look at how we modify a task so that they can manage it independently but not fatiguing to the same degree? Do we need to look at sleep hygiene? Because if they're sleeping all day, do we maybe need to help them, you know, manage that at night time so they're getting into better pattern? Is there an aspect of breathlessness management and task modification from that point of view? And also re-engagement in vocational tasks. From a physiotherapy point of view, we want to look at increasing mobility. Do they need mobility aids? Do they need strengthening and breathlessness management? Dietetics, if they're too tired to eat, yeah, they're going to need to be built up. Psychological support as well, which I think often gets neglected with fatigue, but there is that huge element of that frustration if you can't do what you think you can do and your body won't let you. That's really hard to manage. And also the stress and adaptation to change. And once again, complementary therapies. Get a little bit of relaxation going on. That will improve your energy levels. From a breathlessness point of view, once again, it's much the same. Is it impacting on their mobility? Is it impacting on their ability to get around the house? Does it disrupt their sleep? And this is something that I find a personal bugbear, because I see a lot of patients that actually, if we just gave them a simple aid to put in the bed so they can position themselves upright, they'd get a full night's sleep. They wouldn't be fatigued. They could get on and do what they need to do. Are they having difficulty managing just those everyday tasks? Are they having difficulty talking? Because if you can't talk, if you're so breathless you can't communicate, straight away that's so socially isolating. And so there we go, going on to social aspects. Once again, you know, can they get out? Can they go to work? Can you go out with your friends? Do you have the energy? Or I get a lot of people that are really embarrassed by their breathlessness and coughing all the time, that they don't want to go out and they don't want to see people because they think they're looking at them. And that's just horrible. So they just withdraw. Then they get socially isolated. Can be isolated from a partner as well, especially if they're, say, sleeping in the chair because they can't breathe in bed and then they can't sleep in the same bed as their partner. That's a horrible thing to have to resort to. Anxiety and fear is so strongly related to breathlessness. We all know that breathlessness patients have high levels of anxiety. And it's not uncommon that, especially if people aren't doing the tasks that they want to be doing, that they can sort of have a low level of self-worth and feel guilty about not being able to manage what they're wanting to. And so from a personal values point of view, once again, not engaging in what they feel is their role, what makes them them, and not being able to engage in meaningful occupations, and not being able to attend sort of religious or, you know, events or protocols, it's all impacts. So the obvious first consideration with breathlessness patients is physiotherapy. You know, do we need to get them some breathing techniques? Do we need to look at using some fan therapy? Because I know that's, you know, I think most places are using that nowadays. If you've got breathless patients, you give them that little fan, the handheld fan, and straight away they can get out, they can walk everywhere, the anxiety goes down. So something as simple as a 2-pound little fan, world of difference. Do we need to strengthen the patient? Because as soon as we get those muscles stronger, they're not going to be so out of breath. Do we need to look from an occupational therapy point of view at adaptive equipment? Do we need to look at fatigue management? Do we need to look at, you know, vocational skills? Psychologically, stress and anxiety is such a huge component, and often we need to refer into some support with that. And also that adaptation to change, because once again, unfortunately, our breathing's stopping us from getting out. Complementary therapies, there is some evidence around using acupuncture to help with breathlessness, but also around relaxation just to calm the anxiety when you're feeling breathless. And also, once again, if the patient unfortunately has got to a point where they're so breathless they can't eat, then do we need to look at some dietetic input. And so now we come to my favourite, peripheral neuropathy. And I don't know if many people here do much around peripheral neuropathy, or if they just say, you know, you had cisplatin, it's going to happen. And I get quite a lot of patients that come to me and they have got to this point, and they might be 6 months down the line, and they've got to this point where they can't even dress themselves because the neuropathy is so horrible in their hands. And I just think, you know, why aren't we addressing this when it first comes, when they get those initial tingles, so we're not getting to this point where it's so hard to bring it back? So, what happens when we have neuropathy, especially quite severe neuropathy in our hands or our feet? We stop using those limbs because it's horrible. Who wants to be causing themselves more pain or discomfort? And I don't know if anyone here has ever tried to go a day without using your hands, but it's pretty hard. You use them a lot. And as soon as we stop using them, they get weaker. And so your grip strength goes down. If you try and do anything fine motor, it's so much more challenging. So, and if we're getting in our feet, we stop walking. So we get generally deconditioned, we get weaker, resulting in increased falls risks, trip hazards, can impact on people's, obviously if they're deconditioned, their energy levels, so they get more fatigue, difficulty completing self-care tasks, difficulty, you know, preparing meals, feeding themselves. I had a lady the other day that she stopped going out in public because she can't chop her own meals and her husband has to do it for her and she feels like a child. That's just horrible. Non-verbal communication. In this lovely modern day of technology, we all spend so much time on our phones. If you can't use your hands, how are you going to do that? How are you going to engage with your friends? Straight away, you're socially isolated. Medication management, once again, popping those pills out is not easy. Inability to drive, obviously the continuous pain, difficulty completing most tasks, all those are physical side effects of neuropathy. Socially, a lot of people feel anxious around attending social events, difficulty accessing the community, going to family events, vocational tasks, that is huge. A lot of people can't return to work because of this. And also communicating with others, like I said, using computers, using phones, it's really challenging. Emotionally, frustration, pain-related fatigue. I met a gentleman recently who told me he's stopped using anything hot because he's really worried that he won't have the strength in his hand to lift a pot and he'll tip it all over him full of boiling water, so he's just stopped cooking. Also, low self-esteem. If you can't get yourself dressed, if you can't brush your hair, if you can't put your makeup on, we feel quite nice when we dress ourselves up sometimes, and if you can't do that, that can affect your self-esteem. And also, once again, just that inability to engage in those tasks that you find meaningful and special to you. So, what do we need to consider? And if this is one thing that anyone takes home, please just consider these things. Obviously, pain team, we know they're going to help with the medications. But look at referring into your occupational therapy or physiotherapy team for some hand therapy. We can do things like desensitisation. We can work on grip strength. We can look at adapting the task, so at least they can continue doing it without those negative side effects. Can we look at vocational rehab? From a physio point of view, do we need to review the balance and the strength and reduce the falls risks? Can giving a patient a stick simply help them so that when they're uncomfortable tiptoeing around because of the pain in their feet, they can actually get around and be safe? Psychological support for the frustration and the adaptation to change. And also looking at things around massage, because we do know massage can help with the desensitisation program, and also some acupuncture. And finally, if it is to the point where they can't make their own meals, do we need to look at a dietetic input so we can help them with the nutrition management? So, on that rant, my final thoughts really are, look, we know that the patients are going to have these side effects related to the drugs that they're given, and it's really unfortunate. But just because they're going to get them and we know they're going to get them, they should not be ignored. All side effects that patients are going to experience are really multifactorial, and they really do require an MDT approach. I don't think there's one symptom there that you'd go, I will just refer to one discipline. Think about what you have, whether in-house, in the community, and try and make the most of those services. The benefits of early intervention in optimising outcomes is well established. There's so much research into this. As soon as they present with that grade 1, symptom, refer, get going then. Don't leave it to the point where it's actually stopping them from living. And the most important one, and the thing, as I said, we've all touched on this so far, think about what is meaningful to the person. Not what's meaningful to us, what's meaningful to them, and how can we help them to facilitate this and get their independence and life back, and ultimately, live well. So, thank you.